seminar for you guys. We have some great speakers lined up today, Dr. Miller and Dr. Hazelwood. The focus today will be on arthritis. So I will pass it over to Margaret, who will introduce our topic.
Yeah, so I would like to start off with a land acknowledgement. You will start with the U of C one and then U of A. So I would like to acknowledge and pay tribute to the traditional territories of the peoples of Treaty 7 located in the heart of southern Alberta, which include the Blackfoot Confederacy comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda. That includes the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. And the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Stoney, Iroquois, Ojibwe lands that are now known as part of Treaty 6, 7, 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge, systems, and cultures of all First Nations, Métis, and Inuit nations.
Sorry.
Before Mary goes ahead and introduces her speakers, I'd like to let everyone know that this seminar is being recorded for the talk portion. However, we like to encourage a brave space and open discussion in our question period. So the recording will be stopped for questions, and that is to encourage you to feel safe to ask anything you'd like to the speakers. Without further ado, we'll start introducing them.
Awesome. So I'd like to introduce our first speaker, Dr. Rachel Miller. She's an associate professor in the Division of Rheumatology and in the Department of Physiology and Biophysics at Rush University Medical Center. Currently, Dr. Miller's laboratory is funded by the NIH to uncover the pathways mediating mechanical hypersensitivity associated with osteoarthritis. She also serves as the Director of Behavioral Core for the NIAMS P30 funded Chicago Center on Musculoskeletal Pain, as well as being a co-investigator for the NIH Rejoin Consortium. Dr. Miller has been recognized for her work both by pain and osteoarthritis organizations, and for the last several years, she has served as an associate editor of the Arthritis and Rheumatology and on the editorial board of Osteoarthritis and Cartilage. So I will stop my screen share here and pass it over to Dr. Miller.
Okay, thank you very much for the introductions and thanks for having me join you all today. So as mentioned, I'm here in Chicago, so it's nice to join you all. I'm in Alberta today. If you're interested in learning more about our musculoskeletal pain center, feel free to snap a shot of the QR code and it'll be at the end as well in case you miss it. So today we're discussing osteoarthritis, which is the most common form of arthritis. And this is because the risk factors that lead to osteoarthritis are very common and affect a large proportion of the population. So risk factors include aging, joint injury. Shown here is just an example of a football player getting an ACL injury, or obesity. All of these things can, over time, lead to degeneration of your synovial joints, which is part of the process leading to osteoarthritis. So traditionally, osteoarthritis was looked at by X-ray. So you can see that your joint space is narrowing, your femur and tibia are getting closer together. But now we have advanced imaging technologies like MRI that let us observe other aspects of the disease like synovitis or inflammation of different soft tissues in your knee joint that can also contribute to some of the symptoms arising from osteoarthritis. And so if you were to just take an X-ray of all the people in Canada or all the people in Chicago, a large proportion of them above a certain age would have this joint space narrowing, but not all of them would go to the doctor and complain about their joints hurting. And so it's really this onset of pain that distinguishes the clinical disease and is part of the diagnosis for osteoarthritis. Unfortunately, there aren't so many treatment options that are available for treating osteoarthritis pain, and I'm guessing that we're going to hear more about this in the second talk today. Some options include topical or oral NSAIDs or intra-articular injections like intra-articular steroids. Because of these untreated pain for a large proportion of the patients with osteoarthritis, it continues to be a leading cause of chronic pain worldwide, and it remains the most common reason for patients seeking total joint replacement surgery. So because this is a pain research network, I am guessing that a lot of you are familiar with the anatomy of the nervous system, but in case there's some newcomers to the audience, I'll just go over it briefly. So today we're going to be discussing changes in your knee joint specifically that over time can stimulate your sensory nervous system and cause changes at the level of the dorsal root ganglia, which are these pockets of sensory neuron cell bodies. There's pairs of them at each level of your spinal cord. And the sensory neurons in here can pass the pain signal onward to the dorsal horn of the spinal cord, where the neurons make a synapse. And then the electrical signal can keep going up to your brain, where it's recognized as pain. And so normally you want to be able to respond to pain because that helps to protect from tissue damage. But when you're experiencing a disease that lasts years and decades, like osteoarthritis, these neurons continue to get stimulated. And over time, this kind of good acute pain signal eventually becomes chronic pain and causes changes at all levels of the nervous system. So you can think about this in another way from this cartoon. So normally your pain-sensing neurons or nociceptors would respond to a high threshold signal, like touching a hot stove or hitting your thumb with a hammer. And this would be interpreted as pain. If your nervous system has become sensitized, those same levels of stimuli will be registered as even larger amounts of pain, so higher magnitude pain, but also stimuli that didn't normally used to be painful, like just a soft touch to your skin, could now be registered as being painful. This would be like a sunburn. So in osteoarthritis, a lot of clinical research over the past decade or so has taught us a lot about how patients are experiencing pain and how this pain changes over the course of the disease. So in the beginning stages of the disease, you'll be feeling joint pain if you go out running or if you're climbing stairs when you didn't normally to feel this pain. Over time, the pain can become more spontaneous. So sometimes you might be experiencing pain in the absence of a direct mechanical link. And this pain could also be observed as pain at night, far removed from when you are actually using your joints. And so this can be linked to sensitization of your nervous system. And this is an example in osteoarthritis where osteoarthritis patients are now responding to lower forces when you apply a mechanical force with a machine like this to your knee joint. You can see what force is required in order for the patient to elicit a painful response, and then you record that number. So in a normal person, you would be pressing this device, and people would be more like in the 500s or 600s kilopascals pressing all around your knee joint. But people with osteoarthritis, you can see now they're responding to lower forces. So this is a sign that the nervous system has become sensitized. Interestingly, a study by Lisa Carlesso demonstrated that if you do a sampling of the population, people with lower responses to forces at baseline, those people have a higher chance of going on in 2 years to developing persistent knee pain, suggesting that the sensitization could be used as a surrogate biomarker for your risk of developing persistent knee pain. So in our group, we're mostly using mouse models to study this disease process. And so in our mice, we can do different types of knee surgeries to cause destabilization of the knee joint. So just like I showed on the first slide, if we cut certain ligaments or the meniscus in the mouse knee, over time, this would mimic a joint injury in a person. We can also study naturally occurring osteoarthritis in mice as they age, which normally takes about 2 years in a mouse for this to happen. And so just like I showed on the previous slide, we have a force transducer device that we can use to press on the mouse knee joint to see when the mouse is responding. We can also use other assays like these are von Frey fibers, again, just like what would be used in clinical research. As the disease progresses in the late stage, now we're looking at 12 weeks or 16 weeks after surgery, we can see overall changes in how the mice move around. So we can see that the mice are doing less vertical activity or climbing on the tops of their cages. These are things that mice like to do if you watch them running around. You can also have the mouse stand on little force plates like this, so you can measure how much weight is being put on each hind limb. And so we'll note that over time, the mice are putting less weight on their leg with osteoarthritis compared to the control leg. And so this is all matched up with looking at how the joint damage is occurring. So you can see the cartilage is wearing away, the bone is thickening, there's synovial inflammation or thickening of the synovial lining of the knee joint. And in between these early and late stages, we can look at all the changes occurring in the sensory nervous system and the pain sensing neurons. So we can see that they're responding to stimuli differently. And actually the anatomical locations of these nerves is also changing within the knee joint. So I'll give you some examples of both of these concepts through the rest of my talk. Okay, so diving in on the anatomical neuroplasticity changes. Again, we're looking at a mouse knee joint here. So this is a mouse in late stage osteoarthritis. We can see that the cartilage is wearing away here, but you can also see highlighted in red, this is a marker for nociceptors, the pain sensing neurons. So you can see that they're now growing up through the subchondral bone towards where the cartilage is eroded away, compared to the healthy knee where this is not present. You can also see these nerves growing in the inflamed synovium, again, where this is not present in the normal mouse. So we've done this now in a lot of different models and a lot of different time points, and you can see that it keeps happening. So in all these different models, we can see these nerves growing in the inflamed synovium and also growing up through the subchondral bone over time through towards where the cartilage is eroded away. So this is not unique to mice. Other groups have shown this in rats and also in human samples. So this is an example from David Walsh's lab in the UK. So they were able to collect osteochondral samples from different groups of individuals. So we have people without arthritis, we have people with cartilage damage, but not having symptoms, and we have people at the time of undergoing total knee replacement surgery. So they have cartilage damage and they have symptoms. And so this nicely mirrors what we were observing in the mice. You can see the people at the time of joint replacement surgery have more CGRP expressing nerves growing up through their subchondral bone entering the cartilage, indicating that this observation is likely linked with pain and could give us an indication of future targets for pain. We're trying to study this in 3D now in the mice, so we're using a new technology that allows us to take a whole mouse knee joint. This is on top of a black grid, so normally you cannot see through the mouse knee joint. If you treat it with a series of chemicals, you can actually make it transparent. And so now the same piece of tissue is still sitting here, but you can see directly through it to the grid below. And that allows us to label different proteins or cells within this knee joint and use a special fluorescent microscope called a light sheet microscope to take 3D images of the tissue. So that's what's pictured here. We've used computer software to outline the femur and the tibia. And when I play the video, you'll see the red nerves superimposed on top of the femur and tibia. So you can see that there's robust innervation of the knee joint. You can see there's a lot in the soft tissues in the anterior portion of the knee. But as I mentioned, over time in arthritis, you would be seeing increased innervation on the medial side of the knee joint, which would be on the right side here. We're also able to do similar things using human samples. So this is an example of a piece of subchondral bone collected from an 84-year-old male with grade 3 cartilage damage. So the red here is a marker for all types of nerves, and you can see that there are many nerves in the subchondral bone, but only a few are crossing up into the cartilage. So we're hoping to use this type of technology in the future, not only to study where the nerves are within the knee joint, but also hopefully we could also carefully identify druggable targets on these nerves in these specific locations to try to make safer treatments. So in the remaining time, I'll show you another vignette. Now we're moving to look at functional changes within the knee joint. And so for this project, we're focusing on a particular target. It's piezo2, which is a mechanosensitive ion channel. So this cartoon of the ion channel here, this is expressed on the outside of the cell. And so when the cell stretches, these propellers also stretch out, and that opens the pore to allow cations like calcium to enter the cell, and that activates the neuron and causes it to generate an action potential. And so piezo2 is broadly expressed by sensory neurons. It was discovered because there are actually patients who have mutations in piezo2, and this renders them unable to sense light touch and interferes with their proprioception. But it's also now discovered that piezo2 plays a role in this mechanical sensitization. So what I was mentioning at the beginning, how people are responding to lower forces, piezo2 might be one reason why this is happening. And so this was an experiment done on people with mutations in their piezo2 protein. And so they had patches of capsaicin or saline applied to their skin, and 30 minutes later, the person doing the test touched both patches and asked the person to guess which was the capsaicin patch. So normally, a control person, most of us would be in this category. Your patch of skin with the capsaicin would become inflamed, and if we touched it, it would hurt. Everybody would be able to identify which was the capsaicin patch. However, the people with the piezo2 mutation, they still got the inflammation on their skin from the capsaicin, but they just guessed. So half the time they were right and half the time they were wrong, indicating that it didn't hurt. They couldn't tell the difference between the capsaicin patch and the saline patch. So we were curious to use this paradigm to investigate the role of piezo2 in osteoarthritis. And so when we made genetically modified mice, so we can go in and mimic the piezo2 mutation, but do it in our mice, we can delete piezo from being expressed by all of the pain-sensing neurons in the mice, and then induce osteoarthritis with the same type of knee surgery that we did before. So the normal mice develop sensitization. They're responding to lower forces applied to their knee joint after the surgery, but the mice with the piezo2 conditional knockout do not respond. They still are staying at this high force level throughout the model. It's the same story with the weight bearing. The mice, the control mice start to put less weight on their leg with osteoarthritis, but the piezo2 knockout mice keep putting equal weight on both of their legs throughout the model. Even though the piezo2 knockout mice still develop joint damage, they're not developing this pain behavior. So we've done this now in a few different ways in different models, and we keep seeing the same thing happening. So we were curious what exactly in the knee joint. There's a lot of molecules being produced when osteoarthritis occurs. Is it any molecule that can sensitize piezo2, or do certain ones play more of a role than others? So we focused in on nerve growth factor, partially because there had been a lot of pharmaceutical research in this area there are some large clinical trials investigating anti-nerve growth factor antibodies for treatment of osteoarthritis pain. So this was one of the first trials that was published in 2010, and you can see there is a nice dose response. The people receiving the anti-nerve growth factor drug had less pain while walking compared to the placebo control. However, ultimately, these drugs failed to get FDA approval because every time they were doing a clinical trial, there was a subset of patients that went on to develop rapidly progressive osteoarthritis. And so this is still unexplained exactly why this was happening. But it's unfortunate because for the majority of the patients receiving the drug, it was effective in the sense that it reduced pain levels. So we were curious if there was an overlap between the NGF pathway and piezo2. So we just did a survey in mouse and human neurons, and we found that indeed there was a good overlap. So about 20% of the neurons in both mouse and human are pain-sensing neurons. They're expressing piezo2, and they're expressing the receptor for NGF. So there could be an overlap between these pathways that might allow us to come up with a different way of targeting these neurons to still promote pain relief, but without causing this bad side effect. And so we were curious if we could come up with a way of targeting piezo2 through a local injection so that we wouldn't cause systemic effects of blocking piezo2. And we were looking through the literature, and there weren't so many options available. So there were some spider toxins or other indirect approaches that were targeting ion channels. But we were excited a couple years ago when this paper came out. So this paper kind of reused an old dye that was available. It's called FM143. But what they found is that the uptake of this dye was dependent on piezo2 activity when injected in vivo. So in wild-type mice, when you inject this dye, the neurons take it up, and you can see all the neurons are lighting up here. In the piezo2 knockout animals, when you inject the dye, you can see in the cells where piezo2 is knocked out, the dye can't be taken up anymore, indicating that the dye is specific for piezo2. So when we tried this in our animals, this is an acute inflammatory knee pain model, we saw that using in a dose response manner, we could inject the dye locally into the knee joint and temporarily reverse the pain levels in the animal. This is using our assay where we're applying force to the knee joint. And as the dye diffused out, the pain returned. Quickly, this is now looking at why this would be happening. And so this is a way of actually monitoring in real time the neuron's responses to a stimulus. So we're applying a force to the mouse knee joint, and we can see the neurons lighting up in real time if they're responding to that force. So I try to do that again. So you can see neurons lighting up. You saw some green and yellow neurons here. This is in the control. If we inject the dye, you can see that there are fewer neurons responding, indicating that the dye is blocking the ability of calcium to enter the neuron. So basically, the dye is blocking that central pore of the piezo2 ion channel so that nothing else can enter while the dye is there. So now the big test was, does this actually cause a response when we are looking at our osteoarthritis models? So now this is 7 weeks after surgery. The mice are responding to lower mechanical forces applied to the knee joint. But if we inject the FM dye intra-articularly into the knee joint, we can get a good a reversal of this painful behavior in both males and females. And there's no change in the withdrawal force in the piezo2 knockouts, confirming the piezo2 specificity. This is just to show that a similar thing was happening. If we look in our weight-bearing assay, we get good reversal of the weight-bearing pain with the FM injection, no effect with the vehicle. So to wrap things up, I gave you some quick examples today of different changes throughout the nervous system that can be contributing to osteoarthritis pain. And so we're excited to keep continuing our work looking at local options of targeting these different pain sensing neurons in the knee joint to hopefully come up with better and safer treatment options in the future. So I'll wrap things up and thank all of the people who contributed to this work. So our group at Rush, I lead the lab together with Anne-Marie Malfay, and we have a number of important lab members in our group. We collaborate closely with a group at Northwestern led by Richard Miller, and we have a number of other collaborators. And I'd like to thank the NIH in particular as an important funding source. So thank you very much.
Thank you so much, Dr. Miller. That was really fascinating research. I highly encourage everyone, if you have questions, please feel free to type them into the chat at any point. And while we will be saving them until the end, we can save them and address them then if you have anything on your mind. I will just introduce our next speaker here. Can everyone see that okay? Okay. So our next speaker is Dr. Hazlewood. He is a rheumatologist and professor of medicine at the University of Calgary. His research focuses on medication effectiveness and safety, patient preferences, and clinical practice guidelines in rheumatoid arthritis and other rheumatic diseases. He is the current chair of the Guidelines Committee through Canadian Rheumatology Association and leads Living Canadian Rheumatoid Arthritis Guidelines. So I will hand it over to Dr. Hazlewood here.
Thank you very much for inviting me. I'm just going to throw this in presenter mode. So this is going to be the opposite spectrum from the wonderful talk that Dr. Miller just gave of basic science on clinical practice guidelines that we're doing for rheumatoid arthritis. And I really want to focus on not so much the specific recommendations, which I think are probably more relevant for rheumatologists, but rather our approach to developing clinical practice guidelines in the hopes they may be relevant to a broader audience of pain researchers. Those are my disclosures. So very briefly, rheumatoid arthritis is the most common type of inflammatory arthritis. And by inflammatory arthritis, we mean autoimmune type of arthritis. So that sort of distinguishes it from osteoarthritis. And if you look on the right, this is a typical presentation of someone with rheumatoid arthritis. The circles are joints that are swollen. The blue are joints that are tender. So it's a polyarthritis, affects both sides of the body, small joints and large joints. And our treatment has really evolved in the past 20 years. And the goal in treating rheumatoid arthritis now is remission, which we mean absence of inflammation in somebody with rheumatoid arthritis, usually on medications. So like I was saying, the treatment really sort of exploded around 2000 with the introduction of biologics. And we now have multiple different options for rheumatoid arthritis. So I really spend a lot of my time with research trying to understand which drugs are best, how do we compare the different drugs, how do we synthesize evidence on the risks and benefits and use that to inform clinical practice. And so I want to review what clinical practice guidelines are, briefly on how they're developed, and then discuss some of the things we're doing in rheumatoid arthritis, including where you can access our guidelines. And so clinical practice guidelines, they're really meant to provide evidence-based recommendations on the diagnosis and/or management of a health condition. They should be based on the best available evidence, but I think a key is they don't require high quality evidence. So really the recommendation should be driven by the clinical question, not where the evidence is available. And then we try to find the best available evidence and use that to inform clinical practice. And importantly, a guideline isn't just based on the evidence. Any recommendation requires judgments regarding trade-offs in risks and benefits. So I'll touch briefly on that as well. So what are some of the challenges? I've been involved with developing clinical practice guidelines for a number of years. And some of the challenges we face are in areas where there's an evolving evidence base in treatment, it's really hard to keep up on the evidence. There's tremendous duplication of effort, and I'll talk a little bit about that. And then what do we do when recommendations are conflicting? And it's often challenging, and it's not uncommon where we see recommendations that conflict, and it's often challenging to understand why. So this is a paper we did a number of years ago looking at treatment guidelines for rheumatoid arthritis. At the time, there were 45 different RA guidelines that we identified. The major societies, there's a few, internationally 3 or 4, that update their guidelines every 2 to 3 years, and typically work independently of each other. This is a paper on fibromyalgia recommendations, comparing the different recommendations for treatment. The table extends another page from here. Green shows guidelines that have recommended for an intervention, and red shows guidelines that recommended against an intervention. And this is just showing that there can be wide disagreement across guidelines in terms of how they're interpreting the evidence, what conclusions they're making. And so we've recognized this as a big issue in rheumatology and have really tried to address some of the issues. And so I want to talk briefly about some of the solutions to these problems. So first, with the evolving evidence base in treatments, what's really emerging internationally are living reviews and living clinical practice guidelines. So a living systematic review it's really a systematic review that's maintained over time. So a systematic review where typically monthly literature searches are done, new trials are reviewed in real time, and they may be added either to the review, they're identified, flagged, and then may be added formally to the review now or later. And really that decision's based on if we think that trial would impact the recommendation being made. And so with living clinical practice guidelines, the idea is that the unit of update is each individual treatment recommendation. So you may have one clinical practice guideline with multiple recommendations. Some of those recommendations are not going to change because we have enough evidence to inform them, and it's not an evolving area. But other recommendations can change for a number of different reasons. So we might have a new treatment that's approved. We may have a pivotal trial that comes out or a new piece of evidence on adverse events for a drug that you might want to update a recommendation. Or we may have new clinical questions that emerge over time. And so this is really the model we've introduced in the Canadian Rheumatology Association. And all of our guidelines are available on an online publishing platform, and we use one called Magic App, and the link is there. A lot of different international organizations, WHO, several other major research and clinical organizations use this for publishing their guidelines. And really, the online platform is really essential in living guidelines because you can update them in real time and push out a publication without needing to wait for the journal review process. We still do, our publication model is we update these kind of in living mode. And then when there's an update, we push a notice to our membership. And then periodically we'll publish typically a letter to the editor, just informing when there's been a major update to the guidelines and directing people to the website. This is a link to the CRA website. We have a number of other guidelines that you can view if you're interested. So one of the issues that creates, and really any guideline effort creates, is it's a huge amount of effort to do clinical practice guidelines. It requires lots of funding, takes a long time. The nice thing about the living mode is as opposed to the traditional traditional model of guidelines where you do one guideline and then in 3 years you might publish an update, is you do maintain a lot of the same people and a lot of the momentum over time. So it sort of solves the issue of having to kind of restart and get the guideline back up and running again. But it's still a huge amount of work to do these guidelines. So I want to talk a little bit about what we've done to try to help with that. And two things in particular. One is international collaboration, and then the second is AI, automation, and semi-automation. I'll talk what we mean with that. And so we've really tried to, the CRA is not a huge organization, that's a Canadian Rheumatology Association. And we've really tried to build collaborations as much as possible to develop guidelines. And so this is an effort we have with the rheumatoid arthritis recommendations. Now, we've been working for a number of years with a group in Australia to work on the reviews together. And recently started working with the ACR, the American College of Rheumatology, with the idea being we find out what clinical questions we share between the guidelines and work together on a review to inform all the guidelines. And then each group might go off and do their own recommendations and reviews. But the idea is we try to avoid the duplication of effort that's going on in guidelines. And then the collaboration is really at the level of the evidence summary. So the idea is that the evidence should be reviewed with best methods, but we should be using the same evidence across the different groups. But then each group can go off and develop their own recommendation. This is the review, one of the key reviews we're using to inform our guidelines. So I don't know if everybody's familiar with Cochrane, but it's a large international organization that focuses on evidence synthesis and dissemination. And we run sort of our big reviews through Cochrane. And they have very, very sort of strict guidelines in terms of the methods, strict conflict of interest guidelines, etc. And we're moving towards a method of evidence synthesis called network meta-analysis. And so in a regular meta-analysis, what we do is we find all the randomized trials on a given topic, and we summarize them to find out what's the best estimate for each outcome that we're interested in. And when we do that in a typical meta-analysis, we just look at two interventions, typically one drug versus placebo. In a network meta-analysis, what we do is we consider the whole connected network of trials. So there may be some trials comparing to placebo and then some other trials comparing to active drugs together. And a network meta-analysis is a research synthesis method that allows you to consider the totality of the evidence and generate estimates on each outcome you're interested in for every treatment. And the output this is how we're presenting the output of this. This is a tool called Match It. And essentially, each of the rows is one of the outcomes we're interested in. Each of the columns is an intervention. And for each intervention, each outcome, you can see what the data shows on the drug. It's color-coded to allow sort of a guideline panel to see what the differences are. You can move the columns around to help sort of make comparisons between the different drugs you're interested in. And so that's what we're moving towards. It's a lot of work to get to there. So we've really been trying to incorporate novel approaches for reducing the workload with these. And AI is one thing that's really been coming into evidence synthesis. And it's sort of rapidly developing over time. One of the areas where it's really, I would say, pretty much solved is telling if a trial is an RCT or not. There's a machine learning approach. It was developed through Cochrane, is now built into Covidence, which is a common systematic review platform. And it's really good at telling if something's an RCT or not. So all of our approach to identifying studies is we do a search for every RCT in rheumatoid arthritis. We filter it through here first to get rid of the non-RCTs. It doesn't do a perfect job. It's good at if something's excluded, it's very, very unlikely to be a randomized trial, but it's got a fairly low threshold. So a lot of the records that come to us, a lot of them will still not be RCTs. So it then goes through a Cochrane Crowd, which is a citizen science platform that was developed through Cochrane. And essentially, anybody in the general public can sign up and you get trained. And then it shows people abstracts, asks them to review them, and essentially tell us whether it's an RCT or not. And then there's back-end algorithms. So if you have enough people, like 4 people, that consecutively that say something's an RCT, it gets rejected. And there's other sort of more validated algorithms that help us kind of filter it through. After they go through that step, it comes to another platform we developed, which is, we call it PICO annotation. PICO stands for Population Intervention Control and Outcome. And these are a series of questions that we developed. And what we do is we have trainees, so this isn't open to the general public anymore, but these are trainees that we've identified attached to these different societies that we teach in how to do evidence synthesis. And then they go through and they, there's different incentives that they have for doing it, and they answer these questions to help us further filter the results. We've really been interested in how we can maintain this over time. We've had some grant funding to do it, but to maintain high quality living evidence syntheses requires effort. And so one of the things we've done is how can we provide an opportunity for trainees attached to the different organizations to come in, assist with our review, and how do they perceive that? So this is a study we did looking at what was the value to the trainees in participating in our process. These are the results. So we start, again, we're generating a living database of all the randomized trials in rheumatoid arthritis. And so we started with 42,000, and then we progressively excluded them with machine learning and with the crowdsourcing approach. And then they come into an expert group that does the final review, and then we sort the different trials into the reviews as they come up. And as you can imagine, it's a lot of work to do the first review, but the nice thing is once you have all these processes in place, to maintain it over time, it's a lot less work and can be done with a lot smaller group. That's sort of the first step, and then we extract the data from all the trials. One of the big things we've been working on is how do you assess the certainty of evidence in one of these big reviews? And anytime you do a systematic review, there's part of it which is just which outcomes there are, what the data shows, but then there's the interpretation part in terms of how certain, what is the quality of these trials? How does that affect our overall interpretation? And so I won't go through this in general, but this is a PhD student who is working with us, who developed an approach to automate all these steps, with the idea being we, first of all, decide ahead of time what judgments we're going to, why we're going to make a judgment that a trial is high risk of bias or low risk of bias, how we're going to assess the certainty of evidence according to grade. And then the idea is we set these judgments ahead of time, implement them throughout the review, and then have a person, a human, an expert review it after the fact. So we call this sort of a semi-automated approach to assessing the certainty of evidence. This is one of the graphic of one of the tools that he's developed, where essentially the certainty of evidence and the meta-analysis is done automatically, and then it's presented to experts that we ask them to confirm the judgments that were made using the algorithms that we implemented. Just briefly, there's a ton of work in AI and evidence synthesis and appraisal. I'll give you sort of my 2 cents. I think where it's going to be most useful is things that are clearly validated, like the is it an RCT or not? I think coded algorithms where you've sort of come up with a transparent algorithm that people can follow and understand how the model's working versus large language models, I think are the first thing that's coming. And then I think even when large language models get excellent to the point where they can review evidence, I think we're always going to need a human in the loop, some way to review outputs that are coming from AI, because there's that black box concern. There's the how do we know that what's being generated is a truth. So this is really where AI is going in the evidence synthesis world. And then finally, I want to talk about conflicting recommendations. So this is really common. It's common in rheumatoid arthritis. It's common in, as I showed, in fibromyalgia. I'm sure there's other pain guidelines that conflict in terms of what's being recommended. And so what are some of the ways that we're trying to address that? One is using the same method, so get all these different guideline groups to agree on a common methodology. And then the second, really some conflicting recommendations may happen, and it can be justified, but having transparency in those judgments for why a group recommended something over something else is really the key. So in GRADE, which is really kind of emerging as the international consensus for developing recommendations, the American College of Rheumatology uses GRADE, the WHO, lots of major health organizations use GRADE. And really, one of the things I like about GRADE is it's pretty simple in terms of the interpretation. If you have a strong recommendation, what it means is really nearly all patients would want that treatment given a choice. A conditional recommendation is really everything else. So a conditional recommendation for an intervention means we think the majority of patients would want the recommendation, would want the recommended course of action, but many would not. So you can see conditional recommendations are more attuned to shared decision making. There's an approach called grade adultment, which is a sort of a merging of the words adopt and adapt. And really the idea is that, again, we shouldn't be having different guideline groups review the evidence in silos. We should use one common evidence review so you can share the evidence across groups. But then each group, each country, each context may have differences in terms of acceptability, feasibility, patient preferences, and costs. So that's where the context specific issues come in, where groups can still use the same evidence but develop their own recommendations. And some of the things we're working on with that, with the contextualization, one of the things we've done is developed a health equity framework. So this was led by Dr. Barnaby, who's another rheumatologist in Calgary, who does a lot of work with Indigenous populations and health equity in rheumatoid arthritis. And what she did was to identify through focus groups and interviews what are some of the key considerations for each of 6 identified groups at risk for inequities. And we make each of the guideline groups in the CRA consider these things as they're developing the recommendation. And I'll go through kind of an example of that. I won't go through these in detail, but essentially for each of the different decision points in the evidence to decision framework, we ask the groups to reflect on whether the recommendation would be still relevant in a different equity deserving group. Another thing we've really focused on is patient preferences. So how can we better inform these trade-offs that need to be made? So how do patients weigh the risks and benefits? And so with each guideline panel, we include patients. But we've really tried to do more with that in terms of, can we look at what evidence is out there on patient preferences and bring that into the guideline? Um, Briefly, this is how our guidelines look. And so if you go to our website, you can find this on there. Essentially, there's a recommendation. There's some key remarks that help or sort of the details you need to kind of interpret the recommendation. Um, and then if you click on the evidence to decision link at the bottom, this goes through the whole framework of, okay, how did we go from the evidence that we reviewed into making the recommendation? So a section that talks about patient preferences, what do we know about how patients trade off between benefits and harms? And in each of these sections, we have a line on health equity and what the panel considered when they were making that recommendation. And then it goes through resource use, which may or may not be applicable depending on the recommendation. Another section on equity, acceptability, and feasibility. And this is really where a lot of the differences in country come in. This is an example. So this was a recommendation we did on reducing doses of biologics and targeted synthetic drugs in people with rheumatoid arthritis who've been in remission. And this was an effort that an Australia group there, the ANSMUS group, they developed the recommendation and then we did the development. So we used the same evidence, but came to our own recommendation. And there's a few examples of that where depending on how the panels interpreted the evidence, depending on how they considered these other factors, the recommendation was slightly different. This is an example where actually the health equity came into play, where the panel actually recommended against reducing drugs in populations where it was challenging to get in to see a rheumatologist. And that came from some of the works we had done with that group. So this is really the model we're using, is that to do these AI facilitated collaborative living evidence reviews, to generate the evidence, keep it updated in the living model, and then have each group go and develop their own recommendations, considering those factors that help contextualize the evidence. That leads to guidelines, and then implementation. We're doing some work around shared decision making, and then ideally that identifies research gaps that then feed into which trials are missing. And so thank you. I just want to thank my funders, and thanks to Alberta Pain Research Network for having me speak.
Thank you so much, Dr. Hazlewood and Dr. Miller, for these beautiful, insightful talks. We have some questions in the chat, but before we get started, can we please turn off the recording?